right. So, what are we going to do today? So, today we're going to work on developing your test taking superpowers. All right. Trying to put that last piece of the puzzle. I've been throughout the semester talking about the important study strategies to use to get information in and to get information out. And have made my recommendations as to what the research says and as to what I've seen uh, students be successful with. And hopefully, you guys are out with the old and in with the new. Okay. So, what are we going to do? We're going to talk real quickly about levels of question difficulty. Uh, what is this critical thinking? How is it tested? And then we're going to get into the principles of question STEM principles and answer choice selection principles. How do I choose an answer? And then we're going to apply. So I have, I think, about five questions that we can apply, and six overall, because the first one is kind of breaking it apart. So unpacking. So what are the levels of question difficulty? And I've mentioned this before, it's been in my announcements. And also those of you who completed the remediation assignment, I asked you to try to write some of these questions, some multiple choice questions based on these different levels of question difficulty. So acknowledge just the facts. That's right, Bloom's taxonomy. So knowledge, really, it's just that basic information or concepts. What you may have noticed is Dr. Ross doesn't test knowledge in terms of what does this structure do? I don't ask for just the facts. Why? Because that's what you need to know in order to test, in order to be able to do higher level thinking and answer the questions on the NPTE. And in fact, in order to be a functional physical therapist. Understanding, what is that? That takes it a little bit further, comprehending the basic information or concepts. And what does that mean? It's to be able to determine significance, consequences, or implications of this knowledge. Application is really, really key. And what is that? Using that information, using those rules, applying them to new situations. So theories, concepts, procedures, so on and so forth. Really, that is the nitty gritty of the what we need to do as physical therapists, really what we need to do throughout our lives. We problem solve every day. And of course, on the NPTE. And if we want to even back it up a little bit more, in clinical neuroscience on the quizzes and exams. So analysis, that's really high level thinking, and being able to recognize these relationships, seeing these patterns between the principles, the concepts, and being able to interpret and evaluate the data that's presented. So again, to pass the didactic and clinical education components of DPT school and the NPTE, you have to go beyond that foundational knowledge and understanding. So this isn't something that Dr. Ross made up. So what is critical thinking? It's really decision-making processes where you use your knowledge, your skills, your experience, your logic to be able to draw those conclusions about everyday situations that you encounter. That factual knowledge, again, is going to provide that foundation. You really need to have a strong foundation, right? You can't build a house with Swiss cheese with holes in it, right? But when we're talking about the exam, it's going to really go beyond simple recall of knowledge and facts. It tests your ability to evaluate challenging situations correctly and really make out well thought out decisions about the situation. So you really need to think things through and not look at the question really fast, look at the answers, and then jump to a conclusion. So you draw on your knowledge, your understanding, and you take reasoning to the next level of application and analysis of the information. So that really is what critical thinking is in the healthcare professions. And we call this clinical reasoning and clinical decision making. So let's hop into these question STEM principles and really pay attention, because what I think one of the key issues that a lot of students have is they don't read the question, the whole question, and just kind of jump to conclusions about you think the question asks. So really read that question carefully. What is the question really asking? What is that theme of that question? What is it focused on? And what are some of the clues in the STEM that may be helpful in focusing your thoughts? This is a big issue, over analyzing the question. Don't do it. Interpret the question at face value. Sufficient information is available in the question STEM. Don't go outside of the main point of the information in the STEM to reach a conclusion. Basically, don't read into the question. Don't make up a story. Don't add your own hypothetical conditions to the situation presented. That can lead you down the wrong path. Read the question and nothing but the question. So how do we do this? Okay, so I have you guys read this question right now. And what I want you to do in your head is to think about, what is this question really asking? So I'm going to give you, I'll give you 20 seconds to read that question, 30 seconds. Okay, so you should kind of have an idea as to what this question is asking. So anybody in the comments want to throw out what they think this question is asking? Don't be shy. Nobody? I'm not asking you what the answer is. I'm asking you what the question is. That's good, Leanne and Alex. Yeah. What the artery is involved with this stroke. Excellent. Okay, great. So based on these symptoms, which artery was blocked? And I'm seeing some really nice comments. Okay. So now we want to really look for keywords or phrases in the STEM, such as best, most important, first, of greatest benefit, primary. Often what you'll see is that there can be two answers that are really close together, right? And they might both seem correct. On the NPTE exam, you're going to need to rank those. And I'm kind of getting a little ahead of myself, but you know, what you need to do is make sure you take a look at most likely, what does that mean? What do these key phrases mean? Okay, so it really means set your priorities on answer choices. Rank order the best answer. Okay, so rank them order. Which one is the best based on the context of this question, what this question is asking. So what information in the question stem is needed to answer the question? So what are some things that is going to help you determine which of the following arteries, which artery is blocked? Okay, so impairments. Okay, so specifically, what impairments are those? Symptoms? That's right. Left upper extremity, lower extremity, left neglect. Nothing in the first line. Not for this question. That's good. All right, excellent. So, which information helps you determine which artery it is? So, left hemiparesis, upper extremity weakness is greater than lower extremity weakness, and then neglect on the left side of the body. So, the wheel should be spinning as you're trying to pull up those concepts, right? So, what concepts do you need to know? Do you have to know in order to answer this question? Different arteries. What about the different arteries? Blood supply. Blood supply to what? What area of the brain? Excellent. Excellent. Okay, left side. What links to the left side? What part of the brain affects each hemisphere? Excellent. Okay, the structures and what happens when these different areas, so structure and function. All right, so territories that the arteries supply, symptoms and signs produced by damage to these territories. One key thing, decussation location for those main sensory and motor pathways that we've talked about in the class. Who knows what those main sensory and motor pathways are? What are the biggies? What are the ascending and descending tracks? DCML. Okay, the pyramids is a decussation. That's right. For what? For which track? Okay, so spinal thalamic tract is another track. Okay, so someone's mentioning that cerebellum that we talked about the other day, and lateral corticospinal tract. Excellent. So effects of right versus left hemisphere lesions, and someone had mentioned that too. And remember, we have that lateralization of symptoms. Okay, what is really important and really hard to do is answer the question in your own words before you look at those, before you read the choices. Often what happens, and this is how our brain can play tricks on us, is we quickly read through the question and we look at those answers. And then that's how we can end up selecting the wrong answer choice. So in your head, wheels should be turning, and you should have going through this process of elimination in your head, not looking at the choices. So what arteries supply this region? This is the questions you'd be thinking in your head. The blank artery supplies the upper extremity and the posterior parietal association cortex. Which hemisphere is the artery located in, occluded in? I know the decussation of the sensory and motor tracts is below the lesion. The lesion is above the decussation. What does that mean? I know the artery is located in the blank hemisphere. Why? Because of left-sided paresis, and also we have that spatial comprehension, that neglect. It's lateralized in this particular hemisphere. And then you can say, I know what that occluded artery is. Then look for a choice that best matches your answer. So answer choice selection. Read each answer choice carefully. Don't jump. That's what our brain does. Our brain is built to work fast and to kind of synapse really fast, go from one area to another. Information is located all over the brain. It has that filing system in the lateral prefrontal cortex that we talked about. And cues, we have cues, and they kind of take us to those areas really quickly. Need to eliminate one answer choice at a time. and really give a rationale for why the choice is correct or why it should be eliminated. So you should have a reason why. Sometimes options have some correct information that does not apply to the question asked. Uh, so you want to make sure that you look at that. Sometimes you also see an option where there's some correct answer and then incorrect answer. So you really need to look at those distractors and eliminate them. Identify answer choices that are similar. If two choices say basically the same thing in different ways, some bells should be going off, right? Eliminate them both. More than one choice may correctly answer the question. Choose the one that is most correct. Again, that's that most likely, best, those keywords. And you want to look for overlapping facts in the options. If a fact or statement in one option is incorrect, and you see the same fact or statement in another option, both choices can be eliminated. I'm just going to stop for a minute there. Any of the faculty in the audience have anything additional words of wisdom that I pointed out thus far? All right, let's go ahead and move on to the answers. So here we can see the answers. And what I'm going to do on the next slide, I'll give you a few seconds for this, but it'll be on the next slide too. Answer choice selection. So let's go through this process. It should be fairly quick because you already got those concepts in your mind. So in the comments, which answers can you eliminate and why? Okay, Sakina says left. Why? So because of left hemiparesis, because of the decussation, excellent. And Caitlin says anterior cerebral artery. Why? Since the upper extremity is affected. Oh, that's right. Remember the um, somatotopic arrangement of the motor cortex and the sensory cortex, that homunculus. All right. So any answers with left? Okay. Any answers with anterior cerebral artery? So the correct answer is middle cerebral artery, the right middle cerebral artery. Hey, easy peasy, right, guys? Come on, some jokes in the comments. All right. This is another thing that there's this huge myth, and I hear it from students all the time. And research, this myth that it's better to stick to your first impulse than go back and change multiple choice test answers. That is, yep, I'm sure a lot of people are guilty for that. The teachers, you go on search Google and you'll find that advice from teachers, from faculty. Well, there's research, and this research has been around for a long time. And what the research has shown is that most answer changes are from wrong to right. So what does that mean? That means that most people who choose to change their answers will improve their test scores. Yes, mind blowing for sure. Right? So why is this? Well, just kind of what I said earlier about the brain and how it can fail you at times. especially when it's trying to work really, really fast and that filing system, it sees cues. You know, sometimes that's really important. I mean, we really need to be able to do that. But oftentimes, your first run through for some questions, you don't read it all the way through. So, a word of caution, if you do change an answer, make sure you have a good reason to eliminate your original choice and to make a new choice, right? So I'm not saying this work, I'm not saying this work every time change, you're wrong. Again, that's a myth. That's a myth. So not saying this works every time. And why do we think that? Well, again, this might be a self-reflection post-exam, and our brain can play tricks on us after the exam too. That you changed your answer. So I wouldn't trust that. And there's a really good YouTube video that I'll post for you guys. And the speaker goes through, that how our brain kind of tricks us into thinking that, into focusing that I changed that answer and I had it right. So let's go on to this next question. And I'm definitely going to give you 30 seconds to go ahead. Just read through it. You'll see it again on the next slide. But I want you to kind of get those wheels and gears spinning in your brain. Okay, so let's go on to this next. Now in the comments, okay, what is this question asking? So either on the via the Menti or in the chat box, that's fine. Okay, so Leanne, what muscle will develop a contraction? Okay, great. So what because of yeah, are at risk for contracture, right? And we're already seeing you guys thinking, this is what I need to know. These are the concepts I need to know, and that's excellent, right? So what muscles are at risk for a contracture based on this patient's condition? Okay, so it even goes all the way back to PT fundamentals when you learned about positioning to prevent contractures, and therapeutic interventions when you learned about contractures. So, what concepts do you need to apply? So, yes, we have to apply concepts that we learned from other classes. Wow. So, that means we're building all these tools in our toolbox, all these concepts that we're learning in other classes. They're not in silos. Okay. And you can bet that Dr. Ross is going to have questions that are going to be related to other course concepts that you learned. That's how to become a functional DPT, and also how to pass those boards. So the cause of contractures. So we know that when contractures develop when tissues lose their elasticity because of prolonged joint positioning. And I'm going to just throw this in because it is neural, associated with neurologic conditions. And it can be a musculoskeletal problem too, that's compressing a spinal nerve root. So that's kind of a combined. I kind of look at all of our patients, not necessarily putting them into these little silos, that they're not just neural patients or MSK patients or cardiopulmonary. They're people, and they all have these systems that need to work together. So really, what the key thing is, which muscles are shortened and which muscles are lengthened due to traumatic severance. So you have to know, right? You have to remember, what does traumatic severance mean? And there are other terms for this. other real neurological type words, big words for this, which I'll talk about. You'll learn about that sometime while you're with me. But I went by what the book, which is the most up to date terminology, calls it. So traumatic severance. That nerve is severed. It's split apart of the radial nerve. So you should be thinking back to your gross anatomy about the radial nerve, right? So again, go ahead, tell me. I mean, some of this stuff might seem easy peasy or repetitive, but it's really important. Repetition is the mother of learning. What information in that stem, in that question stem, helps you determine which muscles are at risk for contraction? I know some of you have already, radial nerve, that's right. Okay, so yeah, the muscles that are innervated by the radial nerve. The fracture to the radial head, that's important too, right? Because that's probably where um, uh, the uh, uh, the injury to the radial nerve happened, right? Great. So traumatic severance of the radial nerve, fracture of the radial head, paralysis of the muscles that are innervated by the radial nerve. Okay, so we've already mentioned this, muscles that are innervated by the radial nerve distal to the radial head. Okay, so we've got triceps and wrist extensors. Excellent. Anything else? Okay, we've got extensors. All right. The snuff box, okay. So wrist, finger, and thumb extensors. Okay, and what position will the wrist, fingers, and thumbs be in with paralysis of these muscles? If my wrist, my finger, and my thumb extensors are paralyzed, what position is that wrist going to be, have a tendency to be in? Flexion, right? Do we have a term for that? Have you guys learned what that would be? Okay. So wrist, finger, and thumb flexors, and that is wrist drop. I know I have that somewhere. It's probably on the next slide. Probably giving away answers here. There we go. So which muscles will be lengthened? So this is really key. Okay, going back to your extensors, excellent. So you go back to that therapeutic interventions, your biomechanics, your the positioning of that wrist being in flexion. So wrist, finger, and thumb extensors, right? That's right, because the extensors are not working. So which muscles will be shortened? The flexors. That's right. Okay. So based on this, which muscles are at risk for for a contracture with this condition? The flexors, right? Okay, so it's a wrist flexion contracture. All right, thumbs up, everybody. How about a thumbs up? Understand? All right, great. All right, so now here are the answers. So we have that all in our head. That's our thought process before we even look at the answers. So let's go to this next slide. And just looking at those answers, what can you eliminate? Why can you eliminate them? Do you see any answers that say the same thing? The extensors, right? Because they are elongated. All right. Great. So the extensors, and then that abductor pollicis longus is also innervated by the radial nerve. Okay. And our correct answer is flexor carpi ulnaris. Okay, so what's the question? I saw a question by mistake. Okay, I'm going to move on if it's clear. All right. So let's go on to our next question and give you about 10 seconds. Read through this 2 sentence. Asking us which, so it's asking us which muscle is shortened. That's right. Same thing as a contraction, right? Excellent. Okay, so this is our next question. All right, read through the whole question. Not segmental. Yes. Okay, so what is this question asking? Comments, please. Which vertical tract is disrupted? Okay. What are the deficits due to? Okay, what happens with the cervical SCI? What is vertical tract? That's right. And where are the deficits? Okay, great. All right. What vertical tract deficits will the patient have due to a complete spinal cord injury at C5? Excellent, Caitlin. Okay, we're already starting to get the concepts up there. Everybody's jumping ahead. So, spinal region versus region vertical tract deficits due to a complete SCI at C5. What information in the stem helps you determine the deficits? You guys have already pretty much pointed that out, right? C5, SCI, complete SCI, okay? And the vertical tract deficits, okay? So what concepts do you need to apply in order to answer this question? Vertical versus segmental, excellent. Right? What is a complete SCI? And excellent. Complete versus incomplete, okay. The other concept, lower motor neuron versus upper motor neuron lesion size. Okay, you're definitely when that's part of our segmental versus vertical tract sign. So it's kind of overlapping, but I really feel like I need to definitely bring that one home. Lower motor neuron versus upper motor neuron lesion signs. You should know them like you know your sibling or your spouse or your significant other or your kids or your animals. I'm single. Okay, I get it. But do you have animals, pets, friends, your friends? All right. So I wasn't supposed. Yeah, I think I was supposed to give you all this. I can't remember yet. Yeah. So here's the whole question. I'm going to give you. I'm going to let me time this. I'll give you 30 seconds to kind of look at the answers. They'll be on the next slide too, but just to kind of get the juices rolling in the brain. Yeah, that's true. As a faculty member, it's the same thing. So, All right. You should be able to figure that one out, right? All right. So, which answers can you eliminate and why? Do you see any answers that say the same thing? Okay. It's a little bit higher level. This is what we call combined concepts. Okay. Alyssa can eliminate everything related to lower motor neuron symptoms. Excellent. And I'm seeing some comments in the comment box that are related to that. So uh, there are three answers there that are segmental signs for C5. Can you guys put those in the comment box one at a time or in the chat? The full answer, please. There's two DTRs there. Okay, so why loss of sensation? What is what is that? What is that? Those words saying for loss of sensation? Dermatome, excellent, Chelsea. Okay. And I saw hyporeflexia for the bilateral biceps. What's the third one? What's the third one? That's a lower motor neuron sign. Okay, Leanne's got that one. Fasciculations. Excellent. So, what is the answer? Right, hyperreflexia, bilateral triceps, deep tendon reflexes. Right. So, Dr. Smith, do we need to repost the?
Yeah, some students came in late and I didn't grab the code before you switched the slide. So if we could repost that, that would be great.
Okay, I'm gonna have to go back.
Does any of the students have it where they could just post it?
They could, that's true.
Here it is.
Can you go ahead and put that in there? 198621111. 198621111. Okay. Hopefully I can remember what slide I was on. There. A vertical tract lesion. All right. Gonna give you guys a minute. 60 seconds, maybe a little bit more. This question is pretty easy to figure out what it's asking, right? So I'm gonna go ahead and give you, I'll give you guys 2 minutes. My timer on. It is what it is for this question, right? So you should be trying to work this one out. We'll break it apart, we'll unpack it, but I'd like you to kind of Work it out. 1 minute to go. Make sure you look at this whole sheet. Go through those steps that you learned in class. There's no shortcuts on the Asia. Don't try to take them. It'll lead you down the wrong path. Okay. Let's go on to the next slide. So we pretty much know what the question is asking, right? We need to know what the Asia impairment grade is, right? And don't give the answer yet because we got to go through the process, and maybe it is and maybe it isn't. All right. So what information are you given? That's pretty, we're given that Asia worksheet. So that's pretty simplistic there. So this is where I really want you guys to comment on. Don't give me the answer. I want you to tell me what concepts do you need to apply. So what's the first thing that you did? Okay, so you looked at DAP, right? Okay. What's the sensory level? What's the motor level? Yes, yes. All right. Yes, you have to determine neurologic level of injury. Is it complete or incomplete? But the key is, right? Yep, you have to look at DAP and VAP, AC. Okay, what is that for? Why do we look at VAC, DAP, and then also we look at sensory S2, S3, S4, 5, sacral, right? That sacral sparing. That's going to tell us complete versus incomplete. All right. So what do we need to know? We need to know how to determine sensory, motor, and neurologic level of injury. Let's see, I don't know why I have the answer there, but I guess I shouldn't have told you that. But anyways, hopefully you guys determined that the sensory level was an S1. How many thumbs up for that? Hit the thumbs up button. Okay. So for right and left, S1. All right. And then we have the motor should be L2, right and left. And then neurologic level of injury is going to be L2, right? We take the lowest, the most intact, right, level. So knowing those definitions, those operational definitions, you have to know those like the back of your hand. Get those flashcards out and just keep testing. You guys knew how to determine complete or incomplete. That's sacral sparing. And in this patient, we see that they have, we see 1 out of the 3, right? The DAP. Okay. And is DAP, is that sensory or is that motor? Okay, sensory. Oh, someone says motor. Which one is, what is motor? It's sensory, right? Deep anal pressure means being able to feel that. Motor is voluntary anal contraction. That's right. Does the patient have motor? No, not at the VAC. And that's going to be the lowest level, right? Okay. So how do you differentiate between an Asia A, an Asia B, a C, and D? Well, we already, what's an Asia A again? Complete, right? So we ruled that out, right? It's incomplete because of the sacral sparing. What about an Asia B? What is that? Only sensory, right? Sensory incomplete. Right? So when it comes to this one, the Asia B, you really need to understand what that means. You're saying only sensory, but what is that? Only sensory. Okay. Why do we determine the neurological level of injury? I don't know. Can you guys see the Asia worksheet? Stop sharing and I'll try and share again. This is really key. So sensory incomplete is sensory but not motor function being preserved below. Let me get out my pen here. Oh, here we go. Right here. Very, very key to understand this one. Sensory but not motor function is preserved below the neurologic level. And it's a sensory. That's why I asked, what is a DAP? So if the person has both DAP and VAC, is this a sensory incomplete? You'll have to put that in the chat box. No, Chelsea, excellent, right? Why? Because that's motor, and that's motor below the neurological level of injury, below L2. Okay? Just because they might have light touch all the way down, and they have DAP, they have VAC, they also have motor, so it can't be a sensory incomplete. All right? Jennifer, I'm sorry. I make it as big as I can, and I had it in red. You know, I'm not really sure what else I can do about that. So I had a lot of people get that one correct. So I will look into seeing how best I can do that. All right, let me get back to my Menti. Find it first. This. Oops. I always lose these things. I'm going to stop sharing again. Okay, everyone should be able to see that now. I'll go back to presentation. So sensory but not motor function is preserved below the neurologic level, includes the DAP. No motor function is preserved more than 3 levels below the motor level on either side of the body. So this is kind of, you know, redundant, right? We can eliminate A, we can eliminate C and D and select B, right? Asia, A complete, C and D motor incomplete, and our answer is sensory incomplete. So that's the Asia. All right, I believe this is the last one. So go ahead and take a 30 seconds to read through that and get your brain thinking, what could this be? What is this question asking? Okay. We got some people answering in the chat. Excellent. Give you a couple more seconds. Okay. So what is the question at? What love does what? Okay. Missed that one. Okay, so a most likely location of the lesion in a patient who presents with these signs. Okay. We're looking for the most likely. Okay. I actually think I have another question after this. That's right. I was able to write one more. Autocorrect, yes. That is the curse of technology, right? Typos. So what information in the stem helps you determine what's love got to do with it? That was exactly what I was thinking. What information in the stem helps you determine the deficits? All right, yeah, ipsilateral. Okay, what else? We're already talking about no C-section, temperature, crude touch. That's right. But a secondhand emotion. All right, you're gonna get me singing now. You don't want that. Okay, what's lost and where? Discriminative touch. Okay, so, and that's right, Nerju says DCML and spinal thalamic determine sensation issues. That's right. So what concepts you guys have already started to talk about that. We need to know what the functions are. And so you need to know what these symptoms here, which track is that, right? All right. You need to know where they decussate. All right. And a location of the lesion is going to be based on both track decussations. Right? Excellent. So here are the answers. So let's go to this slide and you can see them. So which answers can you eliminate and why? Do you see any answers that say the same thing? Right? So let's see what people have to say. Caudal medulla, why can you eliminate that? Probably should have said rostromedulla. Sorry about that. Anyways, right? So it should say rostro, okay? Caudal medulla and peripheral nerve are anything above the decussation, yeah. So let's pretend that says rostromedulla. All right. And then actually it doesn't really matter. It can be caudal medulla. Because which sensory tract crosses in the caudal medulla? DCML, okay. Where does the spinal thalamic tract cross? In the spinal cord, yeah. All right. White commissure, all right. So we can eliminate any CNS structures because they are above the decussation. So this should say rostromedulla, and it has to be a PNS structure. So the only thing that is there is the peripheral nerve, right? So these three primary somatosensory cortex, spinal cord, and it should say rostromedulla are eliminated and a peripheral nerve. Okay, last one. Read through this. I guess you could say it's the second best, but it really wouldn't be. That was kind of a goof. I make goofs every now and then, not very often. So. Signs and symptoms associated with GBS. Okay, so yeah, so you guys are getting it. That's right. What symptoms and signs would a patient recovering from GBS present with? And what information does the STEM help you determine the deficits of course GBS? What concepts do you need to apply? It may sound redundant, but pathology and clinical manifestation of GBS. Also, upper motor neuron versus lower motor PNS versus CNS. That's right. Structures and functions. All right. So the pathology underlying Guillain-Barré, you should be thinking about that. And here are the answers. So take a minute, read through those. And let's not put any answers on the slide right now. We haven't really discussed DBS in depth. We will be doing GBS in depth. We'll do that in neuromuscular practice, where we'll really discuss the nitty gritty of those symptoms and signs and the different stages and how these patients go through. So right now, look at the big picture that you learned in the e-learning modules and the textbook, which has that nice little table pathology. All right, so let's go ahead and move on to our choices. So which answers can you eliminate and why? Okay, and Alyssa, rule out upper motor neuron signs and symptoms. I see Nerju talks about Schwann cells. Okay, rule out disuse and spasticity, right? Those are upper motor neuron signs. Okay, great. So any answers with upper motor neuron signs, disuse, muscle atrophy, and spasticity, disuse, muscle atrophy, and paresis, neurogenic muscle atrophy, and spasticity. There's that answer that has one correct, right? We know that our peripheral neuropathies have this kind of atrophy, right? It's rapid, it's massive, 70 to 80% loss of muscle mass. But that's upper motor neuron, lower motor neuron, right? So that could not be the correct answer. Tricky, huh? It's not put in there to be tricky, it's put in there for you to think and to really show competency that you know the difference between upper motor neuron, lower motor neuron, peripheral nervous system, and central nervous system. Okay. So the correct answer is neurogenic muscle atrophy and paresis. All right, so that ends the presentation. Would Dr. Smith, Dr. Morrison, Dr. McFadden have anything additional to add, any words of wisdom that I hadn't discussed? You guys have any questions? Zach?
Hello.
Hi.
So my question is, I wouldn't have asked this question, but you mentioned something earlier when we were discussing critical thinking and like not putting too much into the question. And this not necessarily for the midterm, but for the quiz Monday, there was a question in particular that stood out to me that I got incorrect. And I believe it went something like football player had a concussion and
Mhm.
it stated that I believe it was a mild TBI. And immediately I'm doing what you're saying, doing. I'm like, okay, I could knock off two questions automatically. And that leaves, and I know the material, and I'm like, okay, I can knock off two questions.